normal, and left hand side is the eye which was tested, and by just a glance you see that it looks normal. So thank you very much, and I request our next speaker, Dr. Bibhuti. Yeah.
A very good morning, everyone. And at the onset, I would like to thank Dr. Subhadra Jalali ma'am for gracing our IC with her presence. So continuing with the IC, my topic is pattern ERG. So first up, what are some retinal disorders that are most likely to be confused with an optic nerve disease? Something like a subtle posterior scleritis, central serous retinopathy, Azures, old CRAOs, cone dystrophies, AIRs, autoimmune retinopathies, paraneoplastic, etc. So this is a study done by Dr. Graham Holder in 2001. He had a large case series where he showed that if we do just a visual evoked response, the P100 changes are not actually specific for a neuropathy. It's not specific, and it does not tell you whether it's because of a neuropathy or a maculopathy. And he also showed that the changes in the P50 wave of pattern ERG are a much more sensitive tool to diagnose a maculopathy. And that's where the use of pattern ERG comes in. It enables an optimum pattern VP interpretation. This is an example borrowed from him. This was a case of a 30-year-old man who presented with a decreased vision in the left eye. The ocular examination was non-significant, and a pattern VP showed a reduction in the P100 wave. So the instant diagnosis was something on the lines of an optic neuropathy. But when this patient was subjected to a pattern ERG, there was a reduction in the P50 wave, defining it to be a maculopathy, and later on the OCT revealed a subtle posterior scleritis. So then what exactly is a pattern ERG? It basically is a tool to assess the central retinal response to a structured non-luminance stimulus with the help of a temporally alternating black and white checkerboard pattern, and it is useful to distinguish between maculopathy and neuropathy. In this investigation, the net retinal illumination remains constant. There only is a redistribution of the pattern of the light and dark areas, so called the isoluminant pattern reversal. 3 types of waves are formed, but broadly remembering there are 2 types of waves that are really important for us: a P50 wave and an N95 wave. A P50 wave arises 70% from the ganglion cells, but are actually driven by the macular photoreceptors. And N95 comes from the ganglion cells, and they're the negative waves. So in a maculopathy, the P50 wave goes, and in an optic nerve dysfunction, the N95 goes. So what are the types of ERG? There are two types of ERG. Pattern ERG, the transient type and the steady state. For practical knowledge, just remember that we implicate the transient pattern ERG because they have lower temporal frequencies of less than 6 reversals per second, and they allow for a reliable peak detection, so detection of P50 and N95 is possible. As discussed before, the patients are positioned at 1 meter. They are light adapted with pupils normal sized, non-dilated. Fixation is important, so the patient should be able to fixate. Excessive blinking has to be avoided, and the refraction has to be appropriate for 100 centimeters. This is how the stimulus looks like, and the mean width and height of the stimulus is 15 degrees, and the check size is of 0.8. This is how the stimulus interface in our machine looks like with a red cross of fixation target. The luminance has to be constant, as I discussed earlier. There has to be a high contrast of more than 90%. The reversal rate is lower, approximately 4 reversals, and the frame rate of more than 75 Hertz. The electrodes are the usual that has been discussed before. The DTL electrodes are the one that we use in our practice, and the reference electrodes and the ground electrodes. These are the channels discussed before. I'm not going to go through it again. This is how we place the electrode for pattern ERG. The active electrodes are fixed on either canthi. The reference electrode just beneath the outer canthi, and the ground electrodes on the forehead. And this is how the patient is made to sit in front of the stimulus. These are the gels, the new prepped skin gel and the 1020 conductive paste used to clean the skin and apply the electrodes respectively, just going through so that it brushes the electrodes again for you. This is the short manual that is provided with each with the machine to us, and these have the guidelines as to how to proceed with the pattern ERG evaluation. So when we open up the software, This is how the software interface looks like. We click on the patient, and then it gives us the array of choices as to what investigation exactly you have to do. So we click on the pattern ERG and click on the patient's name fed. This is the examination interface. This is how it looks like. Now, when we look at the bottom right corner, we see the box of impedance. When we click on that, this box pops up. So it basically shows us what exactly is the impedance level of each electrode. So the impedance level ideally should be less than 5 kilo ohms. Now, how do we achieve that? With proper cleaning of the skin and proper application of the gel. And we keep on doing that till we achieve all 4 green signals. And then we start the examination, and then we stop the examination, and then we click on the analyze button, and this is how the waves look like. Now, do these look like a proper P50 and N95? No. Why is that? Because these are very small amplitude waves. And if you notice, the divisions over here are of 50 microvolts per division. So we reduce the scale size to a 5 microvolts per division. This is the maneuver that you have to do while you're examining. And when we do that, we see in for the left eye, we get a very proper P50 and a normal N95 wave. Similar is not the case with the right eye. We get a very erratic wave over here. So what can be the cause? So we go back and check the impedance value, and we see that in the right eye, the active electrode's impedance is high, and that is the cause for an erratic wave. So we correct that. So this detail is not required for us. So what all does the pattern ERG reporting should contain? It should contain the measurement of amplitudes. Can I have the laser pointer? Yeah. So this is the normal printout of a pattern ERG. So what all should it contain? It should contain the normal waveforms of P50 and N95. It should contain the normal values of the various variables that we are measuring. And what are the variables we are measuring? We are measuring the latency and the amplitude of P50 and N95. So the actual values, the normal values, and the waveforms are something that should be incorporated while we are giving the printouts of the reports. Now, where and all can we get an abnormal P50 amplitude? As I said, the abnormal P50 amplitude comes from abnormal macula. So a subtle macular edema, central serous retinopathy, hereditary retinopathies which affect the macula, they will be causing an abnormal P50. Abnormal N95 will come in an optic nerve dysfunction of either type, either a glaucomatous nerve or a neuritis or a hereditary optic degeneration. So pattern ERG is always a supplement to visual evoked potentials and ERG, and various types of permutation and combination of results gives you various types of diagnosis, which usually in routine practice as retina surgeon or as general ophthalmologist we club into one. Of note is that pattern ERG is also detectable in no PLIs, and it can also help you distinguish a central macular dysfunction from a peripheral macular dysfunction. For example, if the central pattern ERG of 15 degrees is abnormal, and if we increase the field to 30 degree and if it regains its normal amplitude, then the central field, the central macula is the one that is affected and not the peripheral macula. What are the uses of pattern ERG apart from this? So it can help in early glaucoma detection in the pre-perimetric phase, or in ocular hypertension when we want to know if the disc is getting damaged, if the nerve is getting damaged or not. It can be used to monitor drug toxicities, and it can also be used to monitor therapeutic success of various drugs in various retinal pathologies. Thank you.
Thank you, Dr. BIBHUTI, for finishing.